Paul, if you want to.
Hello, Paul Belt speaking.
Paul, hi, it's Michelle. If you want,
Yeah.
I'll introduce you, and when my lips stop, if you want to just start.
Okay. All right. That's
Thanks.
fine. That's great.
Great.
Thank you.
Hello, everybody. Thank you for joining us for this short Meet the Specialist session with Dr. Paul Belt, plastic and reconstructive surgeon. This specialist has some amazing credentials and is highly regarded in his field. We look forward to working with him. He writes an excellent report and is very highly regarded in his community. Thank you for making time to speak with us, Dr. Belt, and over to you.
Thanks very much. Thank you, Michelle. I'm just going to share my screen. I'm sorry I couldn't hear what you said, but I share screen, host disabled participant screen sharing. Sorry.
There you go.
I could just share my screen. That's good. Share. Here we go. I couldn't hear what you said, Michelle, but I presume it was all correct. My name is Paul Bell. I'm a board certified plastic surgeon. And I'm doing the Meet the Specialist session for the Medico-Legal Assessments Group today. As I said, I am a board certified plastic and reconstructive surgeon. As a surgeon, I know nothing, but I do everything, as opposed to a physician that knows everything but does nothing. I'm originally UK trained. I'm a board certified plastic surgeon holding the FRACS plastic surgical qualification. I am a supervisor of training for plastic surgery at Greenslopes. I'm also on the state interview selection committee for for trainees. I was also on the curriculum revision workforce, so I'm heavily involved with registrar training. I'm just hitting my 20-year anniversary as entering practice. I do a lot of medical legal work, and I'm also the deputy chairperson for the Work Cover Disfigurement Tribunal in Queensland. Probably my biggest qualification is that I have 4 daughters, 3 of whom are either medical students or qualified doctors. One's an intern, one's about to graduate in 2 weeks, another one's got a year to go, and the youngest one is a physio. So they keep me grounded. As a plastic surgeon, it comes from the Greek plastikos, which means to mold or form. The American Society of Plastic Surgeons has stolen the quote from Gaspari Tagliacozzi. We resolve to restore that which nature has given but all fortune removed, not so much to delight the eye, but to buoy the spirit and strengthen the resolve of the afflicted. He was very famously invented a way of reconstructing the nose. The nose was chopped off by victors of any skirmish. It also was attacked by syphilis back in the day, and he devised a way of reconstructing the arm reconstructing the nose using the arm. As plastic surgeons, we're fortunate we operate everywhere. We do all ages, including in utero surgery nowadays. We handle all tissue types, and we probably pride ourselves on having the best tissue handling techniques. A lot of other specialists will regard us as the hole fillers. We use a reconstructive ladder. We're starting off with the most basic, which is sometimes to do nothing, then direct closure, different forms of skin graft, local tissue transfer, regional tissue transfer, and free tissue transfer. Probably rather than having the ladder, it's probably more of a toolbox, or some people refer to it as the reconstructive supermarket. We've got shelves full of different techniques, any one of which will be suitable, and we would choose the most suitable one to use. As plastic surgeons, we are in a unique niche position, in as much that we have all of the skills available and all of the techniques, whereas some of our lesser trained colleagues may only have a few of those techniques. And if the only tool you have is a hammer, then every screw becomes a nail, which means you may not be doing the most appropriate thing for that patient if you don't have the requisite skill set to offer them the best that's available. We have a very wide scope of practice, including malignancies, soft tissue burns, aesthetic surgery obviously is a huge part of increasing amount of our practices, craniomaxillofacial surgery, head and neck, hand, upper limb, breast, chest, lower limb trauma and reconstruction. I do a lot of medical legal. I largely do the impairment, disfigurement and scarring. I tend not to do the upper limb or hand surgery, as I haven't done that in my own practice for about 10 years. We use the AMA 5th edition, and most of it is done through Chapter 8, Section 8.7, Table 8.2. which grades the various types of impairment due to scarring. Now, the key thing to stress is that most scarring will fall in class 1, which is 0 to 9% whole person impairment. And certainly the table for evaluation of minor skin impairment will subdivide this. Because most patients fall between 0 and 9%, it's clearly demarcated that which is 0, 1, 2, 3 to 4, or 5 to 9% whole person impairment. It's important to note that a lot of our non-plastic surgical colleagues can ascribe or prescribe an impairment of up to 9%. So whenever an orthopedic, for example, assessment gives a scarring of 9%, you've always got to be suspicious that it may be more, but that's the highest that they can give. And in that situation, it may be prudent to get a plastic surgeon to give a more appropriate assessment and appraisal. So as I said, always be suspicious if it's got 9%, because it may be more, but that's the maximum that can be given. A lot of people also use that same table for facial scars, but technically for facial scarring, they should be using chapter 11, table 11.5, giving a whole person impairment of just attributable to scars of the face, and obviously other deformities of the face will fall into this as well. I do a lot of reconstructive surgery, and there's a lot of aesthetic surgery of the breast, and we see a lot of medico-legals. There is actually no specific number for breasts in AMA 5. However, AMA 4 did have breasts mentioned, essentially up to 5% whole person impairment for both breasts in a male, but one breast in female will ascribe 5%, and both breasts up to 10%. And obviously, scarring and disfigurement will get proportions up to 5 and 10% respectively for a unilateral or bilateral case. You quite frequently see reports where they clearly describe a scar and then given an impairment of 0%. If there's a scar, it can't be 0%. It has to be at least 1%. You've also got to consider the other costs: sunblock, protection lifelong for scars, compression garments, a need for moisturizer, camouflage, and makeup. The other question is has this reached maximal medical improvement? Depending on the nature of the scar, the location, and the cause, scars can take certainly up to 18 months to mature, and it may be worth getting the patient back closer to that 18-month anniversary to assess the scar. The scars will mature. The rest of the talk, I was really going to stress about, could a plastic surgeon improve the scar, the function, or the result? And again, even if the impairment's relatively small, there may be a proportionate amount of payout for a reconstructive surgeon or plastic surgeon to actually improve the result. Scar revision. So this is an amputation, a traumatic amputation of the lower limb. It's being reconstructed with a skin graft. This is an unstable end-bearing stump. It's prone to breakdown, ulceration, and it moves, which means it was very difficult to fit an end-bearing prosthesis. This was a relatively easy fix. All we needed to do was literally excise the floppy excess, poor quality skin, and just do a primary closure, allow it to heal, and that's a much more robust end-bearing stump, less prone to ulceration and movement. Again, just further examples. Serial excision. This was a self-harm scar. Now, it gives very classic stigmatizing scars, which a lot of people will recognize as being from previous self-harm. The theory being is that you can excise part of that scar, but the advantage of a serial excision is that your new scar does not extend beyond the boundaries of the existing scar, just because of simple geometry. You allow that scar to mature after a period of normally a minimum of 3 months. You come back in and take a bit more, and then take a bit more, so that what you're left with finally is a single linear scar, which is much less stigmatizing. And that scar is obviously an early scar, as I mentioned before. It will mature over about 18 months and ultimately will give a very fine white linear scar. A Z-plasty is a common and very easy technique that we employ. This is a scar contracture in a patient's axilla. Not only is it painful, but it also limits the ability for them to abduct the arm. They can't lift their arm up past a certain amount. This scar can be quite simply revised using a series of little Z-plasties. This effectively lengthens the scar, reorientates the scar, provides non-scarred tissue into the wound. And the advantage of this is that it not only looks better, it breaks up the continuity of an otherwise very visible scar, but it also will release the scar and give the patient much more arm movement. Tissue expansion. This is an awful case. It was as an older gentleman now, but when he was in his youth, he had a radio antenna when he was in the Army cadets on his back with a big aerial that hit a high tension power cable. The entry wound was his back, the exit wound was his leg, for which he required an amputation. This scar is unstable, it's painful, it breaks down. You can see there's constant ulceration. It also acts as a permanent reminder of a very traumatic episode for when he was a young man. So what we've done is we've basically placed big silicone balloons, which gradually serially inflated over a period of time. We put one in the upper arm, we put one in the back. These are inflated. Unfortunately, it had to terminate before it had reached full expansion because there was a small infection. And then the skin is mobilized as an advancement flap. Didn't quite get rid of the whole scar, so we repeated the process, this time putting a balloon and expander below the scar. And again, this was expanded and then advanced. Still has a small area of scarring, which we could have potentially left, but in order to remove it all, we did a series of serial excisions. And ultimately, he was left with a single fine linear scar. Flap repairs. This is what happens when a young man has an altercation with a combine harvester and a fruit picker. He basically had a traumatic amputation of his leg, hindquarter amputation, unstable scars. This is skin graft over bone. He's got a buried testicle. He's got a buried penis. Obviously, this causes all sorts of problems. So what we did is basically just go back in and recreate the defect. We basically took all the scar tissue away, re-expanded these cicatrized flaps, re-advanced the flaps using local flap anatomy and knowledge of the vascularity on which the skin's based. We're able to place a much more robust flap over the sort of perineum area, unbury the penis, and then put a skin graft over the penis, allowing much easier mixture and potential restoration of sexual function. Dermal fat graft. This is a bilateral cleft lip. This patient has been left again with very obvious show of the incisor teeth. You can see how they become stained because of exposure. Again, this is relatively easy. All we do is we find another scar on the body, remove the skin, and then place the deepithelialized dermis with an underlying bit of fat and place that in to fill a contour defect. Again, it can be used for traumatic indications. These are just the dissolving stitches, and you can see when that's removed, it gives much more balance and a much more aesthetic looking lip. That's where the fat is attached to the dermis. It is possible to do fat transfer. So this was a patient that had fallen, had got an area of traumatic fat necrosis in the arm, giving a linear depression. They also had a traumatic lipoma above it. So what was done, the little circle refers to the lipoma. This is where fat was harvested from an area of excess and placed into this area below where there's a deficiency. Fat was also harvested from other places as well. And you can see that this gives a good restoration. To some extent of the contour, the patient will probably need a repeat go just to try and improve that a little bit more. Trauma and pediatric injuries. So this is what happens when a young child has an altercation with a dog. This is not my case. This was actually Hank Gill's case when I did my fellowship in Oxford. This poor girl, a very attractive young girl, is left with a very, life-changing, awful scar to the nose. As you can see, very hard to go through life, even with a prosthesis. This is a different example. This is whereby we're reconstructing this defect in a patient. This is a skin cancer that's been removed, and we've reconstructed using what's called a composite graft, taking skin, cartilage, and skin from the ear, where we've taken that from. That's reconstructed using a flap repair. It's put on as a composite graft. This is the donor site where the ear was taken. This is the early appearance of the nose, and this is the appearance of the nose at a later stage. And as you can see, it gives a pretty good cosmetic result. The young girl I showed you, the problem with her is that she needed more tissue than you could get to survive just using a graft. A free flap is basically the concept where you have a piece of tissue, in this case it's the forearm, that has an artery going in, the radial artery, a vein coming out, and the whole thing can be unplugged, plugged in somewhere else, and that whole composite of tissue can be kept alive using microvascular techniques. So if you know the vascular anatomy of the ear, the same flap that was the same tissue that was used for the graft in the previous case can actually be transferred based on an appropriate artery, vein, even with some sensory supply. So you use it on the superficial temporal artery and vein, the ear can be disconnected, and a larger piece of tissue can be transferred using microvascular free tissue transfer techniques, which can then be plugged into an appropriate artery. In this case, it was the nasolabial artery. This is an early post-operative result showing a free tissue transfer whereby the ear has been transferred using microvascular techniques to the nasolabial fold. Again, you can just see the expression on the girl's face, how it's made such a difference to her appearance. This is an early scar. This scar is yet to mature. This is her a few months down the track. And I agree, it's not perfect, but it is a much better reconstruction that will actually grow in proportion to the patient. Again, this is an early post-op review. There are some slight area of hair there, which did require laser deepilation, but it will heal dramatically. Again, this just shows you the left and right sides of the nose, the before and after. Not without burden. There is a compromise. The ear has been, you can see where the donor side has been harvested, and the ear doesn't look perfectly normal, but of course this is much easier to camouflage and hide with various hairstyles than something in the middle of your face. Just touching on a different point now, we do see a lot of missed and delayed diagnoses. We see a lot of people who self-treat themselves with this awful thing called black salve. This was taken the day before the patient died. This is not how you treat melanomas. This patient died of metastatic disease. Again, medico-legally, missed and delayed diagnosis. It's really important that the doctors are responsible for chasing their results. The other thing that you can see is that if the original scar is not completely excised from a biopsy, that's an indication that it may be that the surgery is not, that the original excision was not adequate. So again, we reached the 15 minutes. The take-home message is, has a patient reached maximum medical improvement? Is there another procedure that could optimize formal function? And has the permanent impairment been appropriately assessed and maximized? Thank you. There was a few other slides, but as we've reached the time, I think we'll call that the end of the session.
Oh,
thank you.
Yeah, can you hear me?
Any questions?
Can you hear me at all?
Sorry, I can't hear you. I'm sorry.
No worries. All right.
I'm not sure if the chat box is up. Let me end the show here.
The chat, yeah, the chat's there. Would anyone like to ask a question? You can unmute yourself if you'd like. Sorry,
Michelle, I can't hear you. I'm sorry. I can stop the sharing. There we go. Chat box. Okay. I can't see any questions. Does anybody have any questions? Oh, thank you. I've just got your message now. Yeah, okay, thank you. So the question from someone who's not actually listened to it, thanks for a great presentation, Dr. Bell. Would you be able to speak on the role of a plastic surgeon in assessing internal nerve damage? For example, a femoral nerve following hip replacement? Potentially, yes, although, again, you're good at what you do regularly. I must confess, even though we know the anatomy of the femoral nerve, we use femoral nerve blocks. I think that that's probably an area where you're probably better to have an assessment by potentially a neurologist that can conduct nerve conduction studies, somebody who probably is able to give an objective measure of the nerve function. So yes, potentially as plastic surgeons, as any surgeons, we know the anatomy of the nerve, we can assess the function, we can ascribe a permanent impairment. But in that situation, I would have thought that being an orthopedic type injury is possibly better assessed by an orthopedic surgeon, or alternatively a neurologist, or if there was a neuroma or even a chronic pain specialist. A neurologist would be very useful because they could potentially do things like nerve blocks, nerve conduction studies, etc. So in answer to your question, yes, it's possible, but we're probably not the optimate person to do that assessment. There's probably other specialists that are better placed for that. Another question, do you encounter much work where you're called to repair the work done by so-called cosmetic surgeons? Yes, very frequently. I did have a whole series of slides comparing their work and ours, and Fortunately, now there is some legislation, certainly in Queensland and some other states, not in New South Wales yet, where it is now illegal for non-qualified surgeons to call the term surgeons, which means a lot of these so-called cosmetic surgeons now cannot actually legally call themselves surgeons without potential legal ramifications. They do a few weekend courses. They're trained by people who themselves weren't trained. There is a lot of new legislation, which unfortunately has just made more red tape for everybody and doesn't actually tighten up the industry. I do see a lot of cosmetic work that has been done poorly by non-trained plastic surgeons, particularly also overseas work. In Australia, we get a lot from Thailand. But again, that's normally more for reconstructive rather than medico-legal reasons. But yes, increasingly we do see a lot of work that is done by non-trained people. And it isn't so much that they get the complications, everybody gets complications, but it's the way in which those complications are managed or mismanaged that, you know, rather than optimizing what can be a poor outcome, but try and make it the best that they can. A lot of the times their lack of availability and the lack of availability and their inability to actually have the skill set to fix it, rather than doing an early referral to a plastic surgeon, can just dig them into a deeper and deeper hole. So yes, we do get a lot of those cases. And sorry, Michael, sorry you missed the start of it. Does a facial scar rate higher impairment than a hidden scar? I think you need to assess all scars on its merits. As I said, there's a different, you use AMA, the different chapters. As I said, there's one for facial impairment, which is chapter 11 as opposed to chapter 8. Which is the regular scars. And so they have a different yardstick. And yes, a facial scar that's 3 centimeters long in the middle of the face is going to potentially attract a higher impairment than the scar that's hidden, say, on an abdomen, which is generally concealed by clothing and hairstyle. So yes, each scar is taken on its merits. You use the appropriate AMA area and you just try and ascribe it. But again, it's pretty loose with AMA 5 and Temsky for the 0 to 9 for the rest of the body. This is 0, this is 1, this is 2, this is 4, this is 9%. Whereas for facial scarring, it's 0 to 5. So there's a lot of grey areas which is open to interpretation. And certainly my work is in the work cover tribunal. I do know that I was probably, as a junior plastic surgeon, undercalling the amount of scarring. When I work with more senior colleagues, because there's 3 of us that do the tribunal, after doing that for 5 or 6 years, you realize that you're probably not giving the patients as much impairment as they should be. And now it's interesting when you see the reports coming from 2 or 3 different plastic surgeons, even with the big scars, you know, 30, 40%, we're normally within 1 to 2%. And certainly for the smaller scars, we're normally within 1%, I'll be honest with you. Yeah. And again, I'm sure the lawyers, when they look at it, if they get 2 different reports and they're wildly inaccurate or they're wildly differing, they're going to have to get a 3rd report and try and find some, you know, some average between the 2. Yeah. So in answer to your question, yes, facial scars do generally, because it's more traumatic to the patient, it's more harrowing, and it's more visible. It's more of an effect on their function in life. Yeah, exactly. So just one last question. Can you talk about assessment of scarring under a person's hair and how this rates? So alopecia does vary. Again, that's actually, the scalp is not the face, ironically. So the face is the face, not the scalp. So that goes back to, you know, that table of 0 to 9%. But I mean, with certain clothing or hairstyle, or when a patient, you know, goes in the swimming pool, it becomes sun exposed. I will always look inside the hair, and again, if it can be hidden by clothing and hairstyle, is one of the lines in AMA. But I do always, you know, examine it very closely. And also alopecia, if they have a linear scar, if it's making the hair fall into a different orientation, then again, it will invite an impairment, and depending on the severity and the degree and amount of alopecia, will attract a rating for impairment. But it will also give you the potential for a revision, and obviously any cost for that surgery will be borne into account when they're working out the reimbursement or the assessment for the patient's injury, the reimbursement and the payout for any compensation.
Lovely. Thank you so much for your time.
Thank you very much
today.
for your time. If you have any questions, please feel free to contact me. Thank you for your time. Okay. Have a good afternoon, everybody.
Thank you, everyone.